Alaya Lennon. I will first be discussing Case 1. In Case 1, a newborn girl began developing lethargy, hypothermia, and apnea within 24 hours of being born. After a full laboratory panel, she is found to have elevated levels of blood ammonia that quickly elevated. The first part of this case is to discuss the normal mechanisms of ammonia transfer in the body that should be occurring. This process begins with glutamate, which can be deaminated by glutamate dehydrogenase, which produces ammonium ions and alpha-ketoglutarate. Ammonia can either be incorporated into glutamate or release ammonia from glutamate into circulation. Glutamate releases ammonia by collecting nitrogen from other amino acids from transamination reactions and then enters the urea cycle. Transamination is the process of removing nitrogen from amino acids, or it can transfer nitrogen to alpha-keto acids to form amino acids. Ultimately, this is essential for glutamate metabolism. In the liver, glutaminase converts glutamine to glutamate and ammonia, and the ammonia enters the urea cycle. Glutamine synthetase in the liver also converts ammonia into glutamine. In the kidney, glutamine synthetase and glutaminase catalyzes the interconversion of free ammonia ions and glutamine. Normally, increased ammonia levels inhibit glutaminase activity, leading to an increase in glutamine. Glutamate is synthesized to glutamine by ATP and glutamine synthetase. Glutamine synthetase is mainly responsible for the conversion of ammonia that escaped urea production into glutamine, so that free ammonia does not leave the liver and enter the body circulation. The second question is, how is nitrogen transport connected to gluconeogenesis in the fasted state? When fasting, muscle protein is cleaved into amino acids. Portions of those amino acids are converted to alanine and glutamine and released in the blood. Glutamine is oxidized and some of the nitrogens are converted to alanine. Alanine and glutamine then can go to the liver, where the alanine is converted to glucose in ketone bodies, and the nitrogen is converted to urea and excreted by the kidneys. The major amino acid substrate for gluconeogenesis is alanine, and alanine acts as a nitrogen carrier. During fasting, glucagon is released, which stimulates alanine transport into the liver. 2 molecules of alanine generate 1 molecule of glucose, and the nitrogen from the 2 alanines are converted to 1 molecule of urea. Thus, this is how nitrogen transport is connected to gluconeogenesis in the fasted state. Further testing of the patient showed urine orotic acid levels were elevated, and the plasma citrulline level was normal. The next question is what urea cycle enzyme is most likely deficient, and what urea cycle enzyme is least likely to be impaired. The urea cycle enzyme most likely deficient is the ornithine transcarbamylase. In the mitochondria, typically ornithine transcarbamylase catalyzes carbamyl phosphate and ornithine to citrulline, which is transported across the mitochondrial membrane in exchange for cytoplasmic ornithine and enters the cytosol. When ornithine transcarbamylase is deficient, the carbamyl phosphate that would usually enter the urea cycle floods the pathway for pyrimidine biosynthesis. Orotic acid is an intermediate in pyrimidine biosynthesis, so it will begin to accumulate. The least likely impaired urea cycle enzyme to be impaired is the argininosuccinate synthetase enzyme. This is because the enzyme catalyzes the reaction between citrulline and aspartate, and according to the patient's levels, her citrulline is normal, which means argininosuccinate synthetase enzyme should be working properly, or we would likely see decreased levels of citrulline. The last question is which amino acid, if any, becomes essential as a result of the deficiency. The amino acid that becomes essential because of an ornithine transcarbamylase deficiency is arginine. This is because after the synthesis of argininosuccinate, the ornithine cannot be regenerated. With arginine supplementation, ornithine can be replenished to allow the cycle to continue, and arginosuccinate could be used to carry the nitrogen from the body, overall increasing ornithine production and nitrogen excretion in the urine. The next case I will be discussing is case number 3. In this case, a 47-year-old man presents with severe pain in his right great toe with no apparent trauma. Based on his physical exam and his laboratory results, he is diagnosed with gout, which can be caused by several explanations. The first possible explanation we are given is overproduction of purines. So, the product of purine ring degradation is uric acid. Typically, uric acid is ionized in the body to form urate, which is not very soluble. Overproduction of purines can cause serum urate levels to exceed the solubility limit, and sodium urate crystallizes in soft tissue joints, causing gout. This is consistent with the data that the plasma urate levels are increased in the patient. Typically, uric acid is excreted in the urine. Thus, a patient with overproduction of purines would have less urinary uric acid because the uric acid is being crystallized and less is being excreted through the urine. This so far seems like a good answer. The next explanation we are given is decreased salvage of purines. This reflects the Lesch-Nyhan syndrome. Although this can cause gout, there are other symptoms that this individual does not reflect, which is intellectual ability. And the last explanation we are given is decreased urinary excretion of uric acid, which is a symptom of this patient. As we can see in his laboratory results, the excretion of urinary uric acid is low. This is likely the correct answer. Although overproduction of purines did sound like a good answer, this sounds more likely as the patient is slightly above the normal level of plasma urate. It is likely if the patient had overproduction of purines, we would see a significant level of plasma urate. So after further discussion with the patient, we came to realize that he is consuming between 4 and 5 liters of soda a day. This means that the patient is consuming high amounts of fructose. High levels of fructose in the liver cause sequestration of inorganic phosphate and fructose 1-phosphate and decreases ATP synthesis. This ultimately results in less inhibition of de novo purine synthesis by ATP, and the formation of uric acid is increased. Thus, if we can encourage the patient to lower his level of fructose consumption, such as decreasing the amount of soda he drinks in a day, we can likely help him get control of his gout. And that's all I have. Thank you for your time.